Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, a neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about a very fascinating topic, the cavernous sinus and other cranial nerve syndromes. The cavernous sinus and other cranial nerve syndromes, cranial nerves part 75, multiple cranial nerve palsies part 3. Cavernous sinus and other cranial nerve syndromes. Multiple cranial nerves, the clinical approach. The main clinical approach to multiple cranial nerve palsies is to determine whether the lesion lies within the brainstem or outside it. Lesions that lie outside the brainstem are characterized by involvement of adjacent cranial nerves, often occurring in succession, and late and rather slight involvement of the long sensory and motor pathways and segmental structures lying within the brainstem. So outside the brainstem, the cranial nerves get affected but not the sensory or motor pathways, whereas in the brainstem the sensory and motor pathways tend to get affected. So the opposite is true of primary lesions within the brainstem. The extramedullary lesion is more likely to cause bone erosion or enlargement of the foramens of the exit of the cranial nerves, whereas the intramedullary lesion involves the cranial nerves, often produces a crossed sensory or motor paralysis. That is, cranial nerve signs on one side of the body and the tract signs on the opposite side. Multiple cranial nerve palsies outside brainstem. Involvement of multiple cranial nerves outside the brainstem is frequently the result of trauma, localized infections, infectious and non-infections, especially carcinomatous causes of meningitis. So now let's see important cranial nerve palsy syndromes. First, we shall talk about the cavernous sinus syndrome. Multiple cranial nerve palsies outside brainstem. The cavernous sinus syndrome. Cavernous sinus syndrome is a distinctive and frequently life-threatening disorder. It often presents as orbital or facial pain, orbital swelling, chemosis due to occlusion of the ophthalmic veins, fever, oculomotor neuropathy affecting the third, fourth and sixth cranial nerves, and trigeminal neuropathy affecting the ophthalmic and occasionally the maxillary divisions of the trigeminal nerve. So this is the anatomy of the cavernous sinus. You can see the third nerve, fourth nerve, sixth nerve, and the ophthalmic and maxillary divisions of the trigeminal nerves. Cavernous sinus syndrome. The cavernous sinus thrombosis, often secondary to infection from orbital cellulitis, frequently Staphylococcus aureus, a cutaneous sores on the face, or sinusitis, especially the mucormycosis in diabetes patients, is the most frequent cause. Other etiologies include aneurysm of the carotid artery, a carotid cavernous fistula, there could be orbital bruit which may be present, meningioma, nasopharyngeal carcinoma, other tumors, or an idiopathic granulomatous disorder like Tolosa-Hunt syndrome. The two cavernous sinuses directly communicate via the intercavernous channels, thus involvement on one side may extend to become bilateral. Early diagnosis is essential, especially when due to infection, and treatment depends on the underlying etiology. In infectious cases, prompt administration of broad-spectrum antibiotics, drainage of any abscess cavities, and identification of the offending organism are essential. Anticoagulant therapy may benefit cases of primary thrombosis. Repair or occlusion of the carotid artery may be required for treatment of fistulas or aneurysms. Tolosa-Hunt syndrome. Tolosa-Hunt syndrome is an idiopathic granulomatous disorder generally responsive to glucocorticoids. A dramatic improvement in pain is usually evident within a few days. Oral prednisolone 60 milligrams daily is usually continued for 2 weeks and then gradually tapered over a month or longer if pain recurs. Having finished the cavernous sinus syndrome. Now we shall see the superior orbital fissure and orbital apex syndrome. Lesions in the superior orbital fissure and orbital apex cause more prominent visual loss than those in the cavernous sinus due to compression of the optic nerve. The second branch of the trigeminal nerve is usually spared. The cause is often an invasive fungal infection, frequently due to an osseous erosion through the wall of the maxillary, sphenoid or ethmoid sinuses. Now let's see the jugular foramen syndrome. Glossopharyngeal neuropathy in conjunction with vagus and accessory nerve palsies may occur in the jugular foramen, through which all the three nerves exit the skull. Hoarseness due to vocal cord paralysis, some difficulty in swallowing, deviation of the soft palate to the intact side, anesthesia of the posterior wall of the pharynx, and weakness of the upper part of the trapezius and sternocleidomastoid muscles make up jugular foramen syndrome. So, summarizing all the important cranial nerve syndromes, the site involved, the cranial nerves and the usual cause. Orbital apex, the cranial nerves involved are the second, third, fourth, first division of the fifth and sixth. The usual cause is the invasive fungal infections, amyloidosis, granulomatous disease. The sphenoidal fissure or superior orbital fissure syndrome, third, fourth, first division, fifth and sixth are involved. Invasive tumors of the sphenoid bone and aneurysms. Cavernous sinus, the lateral wall of the cavernous sinus. The cranial nerves involved are the third, fourth, first division of the fifth, sixth, often with proptosis. The usual cause for cavernous sinus syndrome is infection, thrombosis, aneurysm or fistula of the cavernous sinus, invasive tumors from the sinuses and sella turcica, benign granulomatous lesions responsive to glucocorticoids. That is a Tolosa-Hunt syndrome. In the retrosphenoid space, second, third, fourth, fifth, sixth cranial nerves are involved. The usual cause is the large tumors of the middle cranial fossa. If the apex of the petrous bone is the lesion, then fifth and sixth nerves are involved. The cause is petrocytosis, tumors of the petrous bone. In the internal auditory meatus, the cranial nerves usually involved are seventh and eighth. The usual cause is the tumor of the petrous bone, that is dermoid, infectious process or acoustic neuroma. In the pontocerebellar angle, 5th, 6th, 7th, 8th and sometimes 9th nerves are involved. The usual cause are acoustic neuroma or meningioma. If the jugular foramen is the site, then the 9th, 10th and 11th cranial nerves are involved. The common causes are tumors and aneurysms. If the posterior lateral condylar space is involved, 9th, 10th, 11th, 12th cranial nerves are involved. The usual cause is tumors of the parotid gland and carotid body and metastatic tumors. If the posterior retroparotid space is involved, in addition to 9th, 10th, 11th and 12th cranial nerves, Horner syndrome is also seen. The usual cause is tumors of the parotid gland, carotid body, lymph nodes, metastatic tumors and tuberculous adenitis. So these are all the important concepts of the cavernous sinus syndrome and other syndromes involving multiple cranial nerves. I hope you have enjoyed listening to these concepts. The other important concepts of neurology, I have put it in a question and answer format in a book, Focused Neurology, written by me, that is Dr. Sreenivas. This book is available online from all leading booksellers including Amazon. If you are interested, this book could be purchased online. I hope you have enjoyed listening to this video of concepts of cavernous sinus syndrome and other cranial nerve syndromes. If you have enjoyed it, please like and share the link. But please subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.